Ms Carey.
Lady, good morning. May I call, please, Professor Susan Hopkins?
I do solemnly, sincerely and truly, declare and affirm that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
Thank you for coming back to help us again, Professor.
Thank you.
Professor, your full name, please.
Professor Susan Mary Hopkins.
Professor, you are now formally Chief Medical Advisor to the UK HSA. You were initially appointed to them on an interim basis in October 2021, formally taking up the role in June 2022. Is that correct?
Correct.
Your qualifications are many and varied. I won't read them all out. But prior to joining UK HSE, is it correct that you were the Deputy Director of the National Infection Service at Public Health England from 2018 to 2020?
Yes.
That is a role that you shared. You are also a Professor of Infectious Diseases and Health Security at UCL in London.
Correct.
And you maintain an active research portfolio.
Correct. I'm also remain in clinical practice as well.
Thank you. You have prepared a lengthy statement, over 181 pages, on behalf of UK HSA for Module 6, and I'm going to ask you about a number of different topics in your evidence. I hope that will conclude this morning or very shortly thereafter. Can I start, please, though, with a summary of PHE, as it then was, role in respect of the adult social care? And if it helps you, Professor, I'm at your paragraph 2.15. Because I think you make the point there that PHE and UK HSA does not have direct responsibility for delivery of adult social care, nor for its regulation.
Correct. So PHE's role in response to adult social care prior to the pandemic and UK HSA now is really to provide advice and support to directors of public health, local authorities and directly to care homes where asked in response to infectious diseases or other external threats. We do this through our regional health protection teams. Our role is also to provide advice to government departments, Department of Health and Social Care in the main, but any other government department can ask for our help and support. We maintain and are the primary source of infectious diseases surveillance data for the country, whereby those infections are notified to us by a hospital or a community setting. And we have expertise in microbiology, epidemiology, and behavioural science and many other areas with over 30 different specialties working within our organisation.
Right. And if we just scroll down on the page that helpfully has been put up, I think the 4 bullet points there probably summarise PHSE's role, obviously conducting scientific and clinical research, as you just mentioned, collecting data on notified infection outbreaks, and as we're going to come on to look at in this module, producing the guidance on IPC measures and indeed supporting the production of guidance owned by others. And there are various other bullets that people can read for themselves there. You mentioned their health protection teams, and we haven't heard a great deal of evidence about those. Can you summarise for us the role of health protection teams, or HPTs? And Professor, can I remind you just to speak a little more slowly, and I will try to do the same.
Great. So first of all, we in UK HSA and our predecessor organisations have 9 regional health protection teams corresponding to the sort of geographic regions of England. This covers England only. In those regions, there are specialist consultants in health protection. By that, I mean a medical or professionally qualified public health consultant, not from an agency, who lead teams who provide advice and support to any range of outbreaks across any setting in that location-based approach. So hospitals, prisons, adult social care homes, etc. They work very closely with their stakeholders, particularly stakeholders in local government and local authorities with directors of public health. They work across the health system and health system network, providing their expertise and advice on individual cases for any infectious diseases that may need follow-up or care, providing advice on outbreaks and incidents, particularly where the outbreak and incident cannot be managed through the routine measures by either a local authority or a hospital or indeed a particular environment themselves. And they are there as our eyes and ears, if you like, as a national agency on the ground. They collect data that is reported to them, which is aggregated up and made available for our national surveillance reports.
Just pausing you there, I think you say that the HPTs were multidisciplinary teams. Can you help with why that was important or beneficial?
Yes, well, first of all, we have a range of people who've come from a range of different backgrounds and locations. So many of the individuals will have previously worked in local authorities, for example. So we'll have a close working knowledge of how local authorities work. Some of the individuals will have worked in the NHS, for example, as infection prevention and control nurses or as other measures. Some of them will have been environmental health officers in local government. And as environmental health officers in local government will have been helping to support local government in how they manage premises, a wide range of premises. We have individuals who are expert at emergency response. So all of that comes together to allow people to bring all of their expertise to bear in the work that's happening in that place-based approach.
Can I ask you this? Is it the case that a care home, perhaps let's say take Liverpool's for example, an individual care home could ring up the HPT for that region and get advice and or support? Would it be that direct link?
So it can be that direct link. It is also dependent on the local authority and their size of team and their capabilities in that local authority. So in some instances, that local authority may actually say, call us first, and we'll deal with the majority, and we will escalate and work with PHE or UKHSA where we need additional expertise and support to manage the infectious diseases outbreak. Right. It's very much hand in glove across the system.
Right. Does it follow that then a provider who perhaps ran a number of care homes, if they didn't go down the local authority route and speak to them for advice, they equally could come to an HPT?
Correct.
All right. What about domiciliary care? Do domiciliary care providers have a link into the HPT?
So our numbers are available for everybody, actually, and if you were a domiciliary care provider and you wanted advice, you could equally call that number. It is highly likely, though, that a domiciliary care provider might call the commissioner of that domiciliary care first, which may be local government, it may be the NHS, in order to get their first line of discussion. But the point of the health protection teams is they are there for everyone in the region. And it is, it may be decided that they would redirect that to somebody who they know is better to answer that question in the region based on that system approach at that place.
And I think you say in your statement that HPTs provided a 24/7 out of hours on-call service, which is operated year-round.
Exactly. So all night long, all day long.
All right. Can I just, before we look at some of the advice and guidance provided by PHE, just deal with a little bit of background? And I think you make the point, Professor, in your statement, I'm at paragraph 4.4 onwards, if it helps you, that pre-pandemic, there was guidance for managing outbreaks, and you set out a number of different pieces of guidance going back to October 2012, coming right up to October 2018. And I wonder if we could just look on screen, or have on screen, please, page 91 of the Professor's statement and paragraph 7.9. I just want to look at perhaps what the pre-pandemic position was, and then we can look at some of the guidance that existed during the pandemic. Here are the guidelines from October 2012 on management of outbreaks of an acute respiratory illness in care homes. It contained advice on discharging patients with flu and presumably other respiratory illnesses. And we can see there in the italicised part, care home residents admitted to hospital with a diagnosis of flu or other RVIs, such as RSV, may remain infectious to others even after discharge from hospital. And infection control measures, as outlined in the guidance, are indicated to prevent transmission. And then if we look down, residents may be discharged from hospital at any point when the following criteria, when their clinically treatment is finished and they've recovered. Appropriate treatment can be completed after discharge. Appropriate IPC measures to prevent transmission are in place, including single room dwelling or cohorting. By cohorting, do you mean that if they've got flu and someone else in the care home had flu, those two residents would be in a wing or a separate area of the care home? Is that what you mean by cohorting?
Yes, we describe that. We describe that in two ways. One is where you place individuals to sleep and reside and share facilities together. The other point is where you can keep the staff segregated,
Right.
though I have to say, both in hospitals and in care homes, that is very difficult to do because it is dependent on the number of staff. It's an ideal, but placing individuals in sharing a room or a living space or a bathroom is what we try and do.
And you can see there that if they're able to put the patient or resident as they become when they come to their home in a single room or dwelling, that will be continued outside the hospital until a minimum of 5 days after the onset of symptoms. So pre-pandemic, there was already in place guidance for when flu patients are being treated to have them discharged when it was appropriate for them to do so, but also guidance to the care home as to how they should treat that patient.
So for an individual who had symptoms or was diagnosed with an infection, yes.
The point I'm making, Professor, is the guidance when we come to look at it is not entirely novel to care homes, the providers and the adult social care sector.
Absolutely,
broadly.
and I would say that we tried to build on established guidance rather than doing 360s, because that would be very difficult in the middle of an emergency to explain and try and discuss with the very many providers. So building on established principles was our process for the majority of the guidance that we produced.
All right. That can come down, thank you. The UK IPC cell guidance that we've considered in other modules as well as this one was primarily for the healthcare sector. Do you agree?
Predominantly, yes.
All right. So can I ask you, are you able to help with who was writing the guidance, generally speaking, from the perspective of the adult social care sector?
So in PHE, we were utilising a team that we had put together especially for writing guidance, because there were so many different pieces of guidance, and trying to bring together the advice that was there for the public, the advice that was the changes in government advice, and the advice that we had as pre-existing together. So we established a new team as part of the response that would write guidance. That was supplemented, and in particular for adult social care, by our health protection teams, who had the local expertise and who worked with care homes on a daily basis for every other infectious diseases outbreak. So it was the guidance team who held the ideas and the centrality of what was happening across government, what was happening in guidance in general, and then the expertise locally, and bringing those together were for the adult social care team. As we went on, we developed a specific adult social care team who held up the core. But from January to April, that was how it was developed.
Do you think in the event of a future pandemic, there does need to be a particular cell focused solely on IPC guidance for the adult social care sector, rather than it being held by a UK IPC cell more generally?
Yeah, so I think from my point of view, what we have done as part of the learning from the pandemic is established a core adult social care team in UK HSA, which we are maintaining. It's not the same size as it was in the pandemic, but it means that we have individuals who are experts at a national level and who are regularly discussing with the care sector and the care sector fora and the department, and who can bring in the relevant other expertise, but they hold the centrality of it. And we will maintain that and extend it and expand it in any future emerging infection.
Can you, just standing back for a second, can you help with why there wasn't such a team in place pre-pandemic?
Well, I mean, I think predominantly the reason the team wasn't in place pre-pandemic is that we had not needed a specific team before, but also resources were extremely tight and had been reduced over the previous 10 years, and therefore we tended to establish teams as we needed them for the occasion, but where possible, we use the generalist knowledge across the agency to provide responses.
Can we go back to January 2020, please? And PHE developed in January 2020, is this right, guidance primarily for the NHS. It consistently referred to a document known as How to Work Safely. Can you help with what is, in a nutshell, the How to Work Safely guidance?
So my recollection, and I think this is the How to Work Safely guidance, is guidance that was pre-pandemic about care home guidance, how to work safely at care homes, the general IPC guidance that was there for care homes about things that they could do to prevent and reduce infections in care homes, things that they might do if they had infections in residents, and that then developed subsequently into specific guidance related to adult social care and COVID-19.
So the January PHE guidance at that time was called the Wuhan Novel Coronavirus IPC guidance. And you say at that time it was developed for the NHS as that was the institution with the highest likelihood of dealing with COVID-19 cases as at January 2020. Does it follow, though, that care homes and the adult social care sector would still be applying 2018 or the 2012 guidance, whichever was more appropriate and applicable?
So to take us back to January 2020, we had no cases in the UK. Cases were predominantly identified in small areas in China, not even in wider areas in China at that point when we released this guidance. And in addition, all of the cases that were being detected anywhere else, even through routine surveillance systems that existed, were always linked to China, and that expanded over time. So at this point, it was really for the management of the NHS for a returning traveller, potentially, who was identified with COVID, why we produced that specific guidance.
Right. Am I right, though, that the first PHE guidance for the ASC, the adult social care sector, was the 25th of February 2020 guidance?
Yes.
Right. Can we look at the February guidance? And if it helps you, Professor, I'm at 4.434 onwards in your statement. Now, can we have up on screen, please, the actual guidance? It's INQ 000223341. It's the 25th of February guidance. And it's important to note that at this point, there was no evidence of transmission at that time in the community, as it says there in the middle of the page. COVID-19 was still designated as a high consequence infectious disease at this time, so it was thought that anyone with COVID would be dealt with in special settings within hospitals primarily.
Correct.
Is that correct? All right. Notwithstanding that, can we see in the middle of page 2, guidance is intended for the current position in the UK where there is currently no transmission. It is therefore very unlikely that anyone receiving care in a care home or the community will become infected. And indeed, I think there were only 13 confirmed cases in the country, none of which were transmissions in care homes as at the time this guidance was published.
All of them were linked to travel or cases associated with travel.
Much. However, it's the sentence that says it's therefore very unlikely that anyone receiving care in a care home or the community will become infected. Can you help me, Professor, with how that sentence has ended up in this guidance?
I mean, I think it was a sentence as statement at that time. I think it was to reassure care homes that if we were detecting infections that were more widely in the community or more in care homes, when we saw that signal, that the guidance may change again. So it was really highlighting that this was a moment in time and things were changing very rapidly, globally and nationally. At the point of this guidance, I think this was just a moment where we were starting to hear cases from Italy, so it was becoming closer. So it was trying to highlight that it was at this moment in time, this is what it says.
Can I just press you on that,
Yeah.
Professor Hopkins? It's a future. It's basically expressed to be in the future. It's therefore very unlikely that anyone receiving care will become infected. It's not. At present, we don't have evidence of people in care homes, but it seems to be rather more looking into the future than this is the current situation.
I have to say, I think that's probably language that is clunky rather than language that is meant to predict what is going to happen in the next month, 2 months, 3 months, based on what we knew in February 2020.
But if it's clunky language, it's meant to be reassuring care homes. It's a bit unfortunate, isn't it?
It is in retrospect, yes.
My lady's really stolen the question I was going to ask,
I'm
but
sorry.
not at all. But really, whether this was liable to provide false reassurance for the care homes, given that you didn't know what was coming across Europe and potentially going to land in the UK. I don't want to be unfair in that criticism, but Mr. Hancock told us, for example, he thinks it should have said, unlikely anyone will be infected, perhaps as a more accurate reflection. What's your observations on that, Professor?
I mean, I can imagine that these guidance were being written rapidly. I think one can always look and improve guidance even after they've been written slowly. And I think that is clunky language. And we would want to improve that language in future events.
Can I ask you about that then? Because let's imagine in 10 years' time we are in the eye of a storm and it's not entirely clear what's coming down the track. What reassurance can we have that there perhaps will be as much put in place to prevent clunky or misguidedly worded guidance? What's going to change when we're in the panic situation that we were this time?
Well, I think I would highlight that this is the first time given that the last pandemic that we saw of respiratory viruses was in 2009 and actually didn't impact society, community or adults in care homes into any significant effect, that this was the first time that we had seen such a thing on a global scale in this way. My hope would be that what we have set up in UKHSA and what the system has set up more widely is better prepared for what we might do in the future. I think we need to keep reiterating and working with the sector and across government and across local government to ensure that we are putting adult social care in the centre of future guidance and in thinking of it for pandemics and emerging infection preparedness. That's certainly what we're doing now. That's certainly what we aim to maintain to do. And we need to ensure that that's at the front and centre of future pandemic planning.
Can I ask you please about page 5 of the guidance and guidance on face masks as it then was at the 25th of February. And if we look at the top of the page, the paragraph beginning, during normal day-to-day activities, face masks do not provide protection from any respiratory viruses such as COVID-19 and do not need to be worn by staff in any of these settings. Face masks are only recommended to be worn by infected individuals when advised by a healthcare worker to reduce the risk of transmitting the infection to other. And then again, perhaps now the unfortunately phrased sentence, it remains very unlikely that people receiving care in a care home or the community will become infected. I know that there is an emerging scientific understanding about how COVID transmits, and we're going to come on to look at that. But just practically speaking, how realistic was it to only advise that face masks were worn when advised by a healthcare worker for people in a residential care setting at this time?
So, I think this is again coming to the preceding guidance that existed for infections in care homes, and particularly respiratory virus infections in care homes, where that was what was the standard guidance and that was what was being declared here. I think when I look back, what we learned through the pandemic was that face masks had a role. I think we still, as we remember in Module 3, don't quite know the extent of their role. But at this time in the pandemic and prior to the pandemic, face masks were not used routinely for individuals who were infected or even for the vast majority of individuals who were being cared for in the community by health professionals. I would highlight that if we suspected somebody had COVID-19 in a care home, the UKHSA HPTs would have been expecting a phone call. Yeah. And therefore, they would have been healthcare workers and advising them, as it is would a GP or an NHS 111 professional as well. So if anyone suspected an individual, there were multiple healthcare workers who would have got involved in providing advice and care of those individuals.
Can I just ask you about the second paragraph that we've got up on screen? PHE recommends the best way to reduce any risk of infection for anyone is good hygiene and avoiding direct or close contact within 2 metres with any potentially infected person. Now, Professor, I'm sure you appreciate that people receiving, particularly in nursing homes, are receiving personal care for across the day, throughout the day. Given that, why is it that PHE are recommending that we reduce close contact when in reality all the care that they're being provided is predominantly close contact?
I agree, care that's being provided is close contact, but there's lots of other more social contacts that can be reduced. And we were at the time trying to highlight that keeping further away and as short as possible time was going to do that. And again, I think it's really important, and I would like to highlight that individuals in care homes have social contact with the staff, and it's really important that that is enabled as much as possible. What we were trying to do was provide assurance to the care home staff about if they suspected an infected person, that if they remove themselves by 2 metres, that would start to reduce their risk. So it was really trying to frame this given that we did not think there was community transmission. We actually, I think in retrospect, have found no evidence of community transmission at this point, that the individuals were unlikely to infect others if they were kept at some distance.
I'm just trying to think about how practically that works on the ground. They have a suspected COVID-19 or a patient with respiratory-like symptoms. They're not advised to wear a face mask unless advised, as you've set out there. But how realistically were they to provide any care if they then had to try and avoid being within 2 metres of the resident?
Well, I mean, if there was somebody with the potential infection at this time, we would expect individuals, and in other guidance that was there, to remove themselves by 2 metres and call NHS 111 or call UKHSA, where the individual would have been immediately conveyed for assessment.
I think that can come down, but I think you are aware that there were a number of concerns raised with the 25th of February guidance. And indeed, I hope you've seen, Professor, a spreadsheet that was provided to PHE for their comment on. And can I have up on screen, please, INQ 4049518, and we may need to expand it. And if I use the column A numbering, can you see down on the left-hand side of the page, row 2, well, on the 27th of February, the National Care Forum via Vic Rayner had a query or a question about the guidance, making the point that care home residents are likely to have their own room, but in many cases they may be using a shared bathroom, and the isolation of those or the proposed rota approach to their usage will be very difficult for people who may need regular support and access to facilities. And then the question is, that concern of the National Care Forums is wrapped up into the question, how do we protect people who are using shared facilities such as bathrooms? And if we scroll over the Excel spreadsheet, there's reference there to the 25th of February guidance. And then the answer is that the health protection team are going to provide advice on cleaning. Can you help me, Professor, with these sort of queries that the NCF and indeed others were raising? Were the NCF and others invited to comment on the PHE guidance before it was published to try and iron out potential unrealities with the guidance and the daily realities for their life in providing care?
I'm afraid I don't know the answer to that.
It just seemed to us that if there had been that engagement, perhaps some of the questions that were being raised would have been answered in the guidance before the guidance came out, and then they had to do it in reverse, if you follow me.
I can see that.
Right. Can I have a look at one other of the entries? Can we go to row 5, please? And it's picking up something we've just looked up. The National Care Forum also raised concerns about the personal contact. The section which details how the disease is spread, either via being within 2 metres of someone or touching their hand, are both cases that are extremely likely with frontline care staff. The nature of the job will mean that the provision of personal care will mean they are close to individuals. The guidance writes as if this might be the exception. Therefore, the expectation in the guidance is that everyone who's had close contact with a person infected should self-isolate for 14 days, is likely to include the large majority of staff within a home setting, and a potentially large number of a home care team if someone receives variable visits from different team members. And Vic Rayner says, I'm not disagreeing with the advice, but really the way it's written does not in any way address the very significant implications of a case being identified in a care home, or I think it's of or it probably should be all home care, or in any way move forward to understand how the ongoing care of the individuals in that setting might be addressed. A real concern there about the care. It's packaged as what action should people take when personal contact is unavoidable, and if we scroll over, PHE answer is, at this stage of the response, residents in social care are unlikely to travel, going back to presumably the ingress of COVID from abroad, and so unlikely to acquire COVID-19. Guidance based on a case-by-case risk assessment will be provided by the health protection team. Now, I understand the context in which that answer is given, but clearly the course of COVID was changing very rapidly, as you've just said. What reassurance was given to NCF and people like NCF when they're saying it's very difficult to implement this guidance on the ground? Can you help, Professor, with what PHE did about that, or what advice they were likely to have been given?
Yeah, so I think, as always, the national guidance is there to set a framework. Our health protection teams work with care homes every day to manage any outbreak or incidents in the care home from a very wide variety of infectious diseases. And so they would often understand the particular care home, how it's built, how it's set out, what the staff are, and work with the local authority about what that might look like. And so in a national guidance scenario, setting out the principle of, if you've got a shared toilet, what you do, if you've got this, it would make the guidance very long and unwieldy. What's there are some principles, and what actually was happening at the time is the care homes were calling health protection teams with questions, and the health protection teams themselves were, utilising their knowledge and awareness to answer those questions and provide and support the care home in delivering their risk assessment. I would also add that the risk assessments on how infections spread in care homes were something that care homes did regularly for respiratory viruses or gastrointestinal infections that occur. And so they are, in some ways, used to this. And what we were trying to do at this point in February was try and give them some important information that could be delivered in a national guidance setting, while recognising that the main route for information was going to be through that established relationship.
I'm afraid I'm not following what extra guidance, national guidance you're giving. Basically, you're telling people running care homes, this is guidance directed at the adult social care sector, isn't it?
Correct.
You're telling them don't use face masks, not necessary. You're saying don't have contact, as Ms. Carey's just asked you, they can't avoid contact in most cases, certainly domiciliary care and a lot of residential care. And you're telling them to have good hygiene. Well, they're going to have good hygiene anyway. So I'm really not following what this guidance directed at the adult social care sector added to what the care home people would have known anyway.
So I think it was putting it together in one place specifically for COVID-19, based on the good practice that was there before.
Now, Professor, you've made the observation that as at the time this was drafted, there was no community transmission. By the 2nd of March, SPI-MO released a statement on the 2nd of March saying it is highly likely there is sustained transmission of COVID in the UK at present. So within a number of days, we've gone from there being no community transmission to now sustained transmission. And SPI-MO said it is almost certain there will be sustained transmission in the UK in the coming weeks. The next guidance that came out was on the 13th of March. And it may be observed that if SPI-MO are saying on the 2nd of March, we've got it now in the UK and it's coming, why did it take another 11 days for the second set of PHE guidance to be produced?
So just to ensure, so the SPI-MO paper at the time would have been a paper to go to SAGE, so for a SAGE discussion. It wasn't publicly released, so I don't think those papers were publicly released for a long time, and definitely even within government they were held quite tightly. So as far as I know, I definitely didn't recollect seeing it as the incident director for Public Health England at the time, though clearly we'd had our first community case on the 28th of February, so that was our first detection in the community. So from my point of view, the work that was done over that next couple of weeks my understanding from the teams who I've discussed with when building this evidence statement as the corporate witness, my understanding is that they were then discussing this with the department, we're discussing it with the health protection teams, we're discussing it with the care homes, so that, again, it was following on from the answers to the questions from the spreadsheet that you've shown me, trying to work and utilise all of the experts across the organisation and externally to provide an updated and improved set of guidance for the next situation where we were seeing some transmission in the community.
Do you think, had PHE been aware of the consensus statement that SPI-MO had put out, PHE practically would have been able to respond quicker with guidance within a couple of days as opposed to 11 days later?
So perhaps, but I think, as you've said already, that actually there's a balance between working with people, ensuring that you're answering all the questions adequately, ensuring the guidance is meeting the needs that of the sector that it's going out to, and the speed and haste. And actually that was a difficult balance throughout this period.
And before we then come on to the March guidance, just thinking back to this time, do you think that the February guidance perhaps should have highlighted the possibility that there may be transmission coming and warned the care sector to generally monitor the position more carefully? I don't mean by them looking at the actual stats, but just to say, we don't quite know what's coming yet. Please be ready to deal with infection rates rising if we start reporting them in the press.
I think in hindsight, yes. I think that's not what the general consensus was at that time. So it's important to try and put oneself back at that moment in February 2020. I think as we go forward with guidance, trying to have and working with care homes and the care home staff to have an increased alertness over general infections is really important. And I think that alertness, awareness, and the closer working relationships that have developed over the pandemic and since then actually stand us in good stead.
In your statement at paragraph 3.29, Professor, you say asymptomatic infection was documented by the end of February, March 2020. However, the available data remained inadequate to provide evidence of significant either pre-symptomatic or asymptomatic transmission. Now, we're aware of the distinction between the two, I can assure you, but given that asymptomatic infection was certainly being documented at that stage, do you think perhaps the February guidance should have been more cautious and alerted people to the potential of asymptomatic transmission, albeit you didn't know the precise extent of asymptomatic transmission at that point?
So I think this is really important. I mean, we talk about how we build on the guidance that has gone before. I mean, you know, we sit in this room now in a different time, but with many other infections circulating. And, you know, what we're doing at that point was trying to highlight the risks of this new and emerging infection, of which we knew very little, but not trying to go into the world of what it was like in that middle of 2020. From my point of view, we do not routinely and continue, so post-pandemic, do not routinely tell people to be particularly wary of asymptomatic infection for any infections, because what we're trying to do with infections is to try and find the people who have got symptoms and treat that disease and prevent them spreading. And I think COVID-19 was one of those first infections that we actually saw a very large amount of, for respiratory infections, I say, very large amount of asymptomatic transmission over time. But at this point, what we were doing was utilising the evidence in the past that said, if you have asymptomatic infection, the likelihood of you transmitting the respiratory infection is very low, which we'd used for flu, which had worked us in good stead for many other respiratory viruses over many, many years. And trying to utilise that rather than change the basis of the science that we were utilising was what we did at the start. I think we learned a lot over those current months, and I think that we could consider how that learning would take us forward in a future infectious diseases respiratory-related pandemic.
Can I come on to the March guidance that was published on the 13th of March? We know that it was in three separate, one for residential care, one for home care, and one for supported livings. And I just want to look with you, please, at sort of the lead up to that and in the actual guidance itself. And in your statement, Professor, you say that on the 2nd of March 2020, I'm at your paragraph 4.50, Public Health England contacted DHSC to offer PHE's assistance in developing a response for the social care sector, particularly in respect of engagement on a local level with ASC stakeholders. Can you just help? What was PHE actually offering here?
So my recollection is that the chief exec of PHE at the time emailed the director of adult social care in the Department of Health, particularly because, as I've mentioned already, our health protection teams had a strong local link with the adult social care sector in the locality, with the providers and with the commissioners and local government. And I think it was generally reflected that the Department of Health and Social Care had taken on social care responsibilities in 2018, but did not have those strong, robust links with the sector at the time of the end of February, beginning of March. And so we were offering our support in the guidance and any of the areas that the department wanted to work with to develop the future adult social care guidance.
You go on to say that on the 8th of March, DHSC had emailed raising concerns that the February PHE guidance was, quote, not meeting the needs of the care sector, close quote. And no doubt reference perhaps to some of those item entries we looked at on that Excel spreadsheet. And DHSC asked for a plan for updating the guidance. Can we just have a look, please, at really what was missing from the February guidance, if I put it like that? And it might help you if we have a look on screen, INQ 000325229 _ page 2, please. Thank you very much. This is an email on the 9th of March from Ros Rawton to a number of people in PHE, talking about the draft guidance. But can we see in that first paragraph the comments on the guidance headed guidance for social, community care, residential settings? That's the 25th of February 2020 guidance, isn't it?
I don't know if the comments on the guidance were on the 25th of February or the new draft guidance that was being developed.
They are talking about, I think, changes that they are proposing for the 25th of February guidance. All right. And you can see there, I recognise the guidance has been through several clearance procedures. I'll minimise my comments, but the comments are about patients. We need to be clear it's not just elderly people who are vulnerable. It might also be children with complex conditions. Setting, the language is all about care settings. We should be clear this applies to people being seen at home by home care workers. It makes clear at one point in the background, but I think the reference continue to care settings seems odd. Could we say care settings or people's homes? It's concern about the definition of close contact. Missing questions from the sector. This doesn't cover quite a lot of things that I know the care sector would like to see if COVID-19 becomes more widespread. This is where the need for more detailed guidance. So do we need to signal there'll be further guidance on the management of COVID-19 settings in the event that there is a wider outbreak?
So could you remind me, Ms. Kay, the date of these comments?
This is the 9th of March 2020.
Thank you.
And so it's Ros Rawton raising with PHE a number of concerns about the guidance. Do you know, was any engagement with the care sector being envisaged in the run-up to the publication of the 13th of March guidance?
So again, my understanding is that Ros Rawton and the adult social care team were leading that engagement. That's where the inquiries had come from, and that they were leading the discussion and engagement with the adult social care sector, but that members of PHE, such as Paul, as in this email, and others leading on the adult social care guidance, would have been attending those meetings with them. I don't have records of what meetings took place and when they were.
Now, the 13th of March guidance said that if neither the carer nor the person being cared for was symptomatic, no PPE was required. Excuse me. Given that by the 13th of March there is now community transmission, and I assume PHE puts the SPI-MO document to one side, I assume by the 13th of March PHE knew that there was community transmission?
Yes.
Can you help with why there was no reference in the 13th of March guidance for the need for PPE if neither the carer nor the person being cared for was symptomatic.
So again, this is based on the established principle, which actually was the same in hospitals. In hospitals, if neither the carer, the patient or the carer had any symptoms, that would not have required PPE either. You only used PPE in hospitals or any other setting in all the years prior and at this point in the pandemic in all settings for individuals who are symptomatic. So I think this is not just as something specific to the adult social care sector. This was the widespread management of infectious diseases and continues to be the widespread management of the infectious diseases post-pandemic, where PPE is predominantly used for those individuals who are symptomatic.
Now, clearly, that guidance did not protect against asymptomatic transmission. Was there a reason why, as at the 13th of March, the protection against asymptomatic transmission was not written into the guidance?
So again, I would say that at this point, asymptomatic transmission was thought of as highly unlikely still. Not impossible, but actually the balance of evidence was that that was not what we were seeing in the main. The reports were talking about individuals were being detected with asymptomatic infection, but that is not the same as who is most likely to transmit. And the consensus at that time remained that the people most likely to transmit were those with symptoms, not those without symptoms and who are fit and well.
For the avoidance of doubt, was the reference to there not being the need for PPE unless the person was symptomatic or the carer was symptomatic, anything to do with a limited supply of PPE that was prevalent at this time?
No, that was the way IPC was managed throughout all sectors, before and during at this point.
Can I ask you about two particular pieces of the 13th of March guidance? I'm going to have on screen INQ 000 300 278, page 3, and then we'll look at page 4. And if I could have blown up, please, the bottom paragraph. How care homes can minimise the risks of transmission. As at the 13th of March, is it right that PHE advised care home providers to review their visiting policy by asking no one to visit who has suspected COVID-19 or is generally unwell? But there was no blanket ban, certainly, in this guidance. Is that correct?
Correct.
And can you help with why, at this stage, care homes weren't advised proactively to ban visitors?
So, I mean, I think from my point of view, where we stood at that point is that there was community transmission. We were seeing rising numbers entering hospitals. It got extremely rising numbers over the following couple of weeks. I can't remember the exact number of cases on the 13th of March, but it was definitely below 100 cases detected in the whole country. That's quite a small number for a population of 70 million. So it was really in the small numbers. But we knew that there was community transmission happening. From my point of view, what this is again trying to continue with this sort of standard advice that would have been available in winter, where we asked visitors not to attend if they're unwell with respiratory viruses in general because they can transmit. So in the sense, this was trying to highlight for COVID-19 to continue that, to review that, and to highlight that individuals who were visiting should have good hygiene and not be symptomatic with respiratory illness.
Can I go over the page, please, to page 4 and the guidance issued where a resident has symptoms of COVID-19? And if we could just have the top paragraph blown up, thank you. Care homes are not expected to have dedicated isolation facilities for people living in the home, but should implement isolation precautions when someone in the home displays symptoms of COVID-19 in the same way they would if an individual had flu. If isolation is needed, a resident's own room can be used. Ideally, the room should be single bedroom with ensuite facilities. Now, Professor, can I ask, reference to isolation precautions, what did that actually mean for the person that was reading the guidance trying to implement it?
Well, again, I think that it will have had other elements mentioning that. In this guidance, it did, as I recall, which is gloves, aprons, and a face mask. And that will have been in other parts. Actually, it says aprons, gloves, and fluid-repellent surgical masks in the next paragraph. And if there is a risk of splashing, then eye protection will minimise risk.
So the isolation precaution was actually to put on various pieces of PPE.
As well as if isolation is required, a resident's own room
Yeah.
should be used. So it's a group of measures that you do to reduce the risk of infection.
The reason I ask you this is if the resident has the symptoms of COVID-19, how is the care home to know if isolation is needed or not? I just wonder if this piece of guidance is explicitly clear about what you're telling the care home to do here.
So I would have to go through it, but I'm pretty sure that it's saying that in this guidance, if the individual has COVID-19, that the individual should be isolated, and that in further place in this guidance, it will have spoken about calling the health protection team for advice.
It certainly makes reference to calling the health protection team, but I've checked and it doesn't mention isolating the individual if they have symptoms of COVID-19. And that's why I wanted to ask you about it, because the only reference to isolation is this paragraph here for people living with COVID-19, but they should implement isolation precautions, i.e. putting on gloves.
And if isolation is needed, a patient's own room can be used.
Yeah, but how was the care home to know if isolation was needed? You're not directing the care home to isolate.
I understand that you're saying this. I think that with many years of experience in isolation precautions, adult social care would have done that.
All right. There's nothing in this guidance about how long the patient with symptoms of COVID-19 should be isolated for. Can you help us with why there isn't a time limit or a time frame put on how long isolation should be for?
I think this was also trying to utilise the generic guidance that was available for the public that was issued approximately at the same time, which was that if you had symptoms of COVID, you should isolate for 7 days.
Right.
Subsequently, in care homes, that was lengthened because of evidence that elderly people shed the virus for longer.
Just reading this, it doesn't sound very directive to care homes, if I might put it like that. You could do this, you can isolate, have isolation precautions. If isolation is needed, then isolate, but we're not going to tell you how long for. Do you think this was sufficiently clear for care homes when it was drafted for dealing with people where they had symptoms of COVID-19?
I think looking at this now in isolation, I'm sure we could improve the clarity. I think it's really about the discussions that were being had with the care homes and the health protection teams at the time.
I asked, Professor, because 4 or 6 days later, depending on which date you look at, we have the hospital discharge policy coming out to from NHSE, I should say, on the 17th, and then the actual guidance that accompanied it on the 19th of March. So given that we're about to have an expedited discharges, do you think upon reflection that the 13th of March guidance should have been more explicitly clear about the need to isolate people with COVID-19 symptoms?
I would highlight that PHE did not know about the 17th of March guidance at this time or on the 17th of March.
Yeah. So you have the left hand and the right hand not necessarily know what they're doing, leaving the care home in the middle without the explicit guidance to isolate the resident if they have COVID-19. But the hope and expectation they will know from previous guidance they should be isolating. Is that what it comes to? Well,
I think that, I recognise the challenges looking at this guidance. I completely do. In hindsight, 5 years later, I look at it cold and it looks like this. I think it's important to acknowledge that and important to build that into improved guidance for the future. The point of the time was that there was established procedures for isolating individuals with respiratory infections. And this was building on this and talking about COVID-19, with the ability for every care home to contact the health protection teams and have a discussion about the individual management, and recognising that it was really dependent on the care home shape, size, building, and that trying to write the guidance for the very wide variety in sizes, capacity, capability was quite challenging. So I think the words are not necessarily not as instructive as delivered as points of you must do in order to facilitate the various challenges that the care home sector might have had in delivering it.
Now, 2 weeks after this guidance, there was the Washington Care Home results published. If it helps you, it's at your paragraph 3.30 onwards. But on the 27th of March, the Washington Care Home study published an early release of their findings. And without taking you to the precise detail, do you agree, Professor, it was an important study in relation to asymptomatic transmission at that stage, because it tended to suggest that there was evidence now of asymptomatic transmission?
So that's not what the study had said, actually. The study highlighted that it referenced potentially asymptomatic infection. It said that this may suggest that there is, and the relative contribution remained uncertain. And so it's really important that it was actually the study that, when it came out, there was a lot of interest globally because it was the first care home study. I would highlight that 3 out of the 23 that tested positive remained asymptomatic throughout. So it was really potentially highlighting that people were testing positive before they developed symptoms, and that gave us an early inclination on that.
Notwithstanding that, though, it was evidence now of some asymptomatic transmission. Do you agree?
I think there was potential. I don't think we can say for definite.
All right, so you wouldn't...
This was not
just
definitive
a study.
evidence. It was a single study in a single care home with a small number of residents, and where we needed to build on this and understand it better.
Right, so what were the implications, if any, of the Washington study on subsequent guidance?
So, I mean, I think that, first of all, the implications on that were really about highlighting, I think the following week, we released the sort of wider guidance about wearing PPE more regularly for all staff and residents in care homes and hospitals, particularly because of the asymptomatic infection risk. That's the first thing. Secondly, it really helped us to ensure that we were developing our own studies that were larger and across a multiple variety of care homes, which was subsequently done at the Easter weekend, less than a couple of weeks later, as soon as we had testing capability. And it fed into then the wider guidance that was subsequently developed on care homes, and to the idea that we would have wider testing in care homes at subsequent moments.
Bearing that in mind, on the 2nd of April, there was the admission and care of residents during COVID-19 incident in a care home guidance, more easily expressed as the April admissions guidance. And I'd like to ask you about that, please. And it may help if we look at it on screen. Can I have on screen INQ 528401_4, please? This is from the April admissions guidance, and I'd like to ask you, Professor, please, about the paragraph there with the bold highlighting in it. It makes the point that the care sector is looking after many of the most vulnerable people in our society, that the national effort, the care sector plays a vital role in accepting patients as they are discharged. Residents may also be admitted to a care home from a home setting. Some of these patients may have COVID-19, whether symptomatic or asymptomatic. All of these patients can be safely cared for in a care home if this guidance is followed. In this guidance, there was advice that symptomatic residents be isolated and cared for in a single room. There was no advice to isolate asymptomatic admissions to a care home. Can you help us with the sentence, all of these patients can be safely cared for in a care home if this guidance is followed? Because many may think that was a rather bold claim to make. And so what does PHE say to that?
So first of all, just in my recollection of this is the guidance that was led by the department, coordinated by the department with NHS, CQC and Public Health England. So it was a consensus guidance across the 4 organisations. The final version of this guidance will have been reviewed by ministers and seen by the Office for the CMO and reviewed by them as well. So it will have had a lot of different views in it. I think, again, on learning, there's very few times that I would say all or 100% or in guidance now, because I think it's far too certain, especially as knowledge was evolving. I don't, and I can't say why it was decided to put those exact words in there. And I think looking back, it is potentially too reassuring to the sector from where we are right now. But I would then also add is when we talk about asymptomatic infection, it could mean every single person in the care home and every single staff. So it's trying to weigh up the balance of finding the people who've got symptoms, who you want to ensure that they're not spreading, versus the rest of the care home residents and staff, where you want to ensure that they can continue to live their lives as much as possible and be cared for in the way that's right for them. So it's always that sort of balance of risk and benefits in this.
You say you can't answer now why or who inserted it, why it was included. Do you know whether it was designed to ensure that hospital discharges didn't get blocked by care homes? Was that really what the tenor of this was about?
So I definitely recall that there was a large amount of discussions about ensuring that hospitals had the space to look after the severely ill individuals of all ages who required hospital admission, hospital treatments that are only available in hospitals. And at this point, there were increasing worries that we were going to run out of hospital beds. Nightingale hospitals were being built, for example, to try and provide extra capacity. I also know that in the routine, as we set out at the very start of the looking at the guidance, care individuals are discharged from hospital to a care home once they've had their initial acute episode treated, whilst they may still have elements of infection. And of course, on a normal basis, many individuals get discharged from a care home who may be asymptomatic as well, but we don't routinely test them for other infections.
Can I ask you about PHE's work in the build-up to the consensus admissions guidance, if I could call it that? Can we have up on screen, please, your paragraph 7.16? It's pages 94 and 95. And if it helps you, Professor, I'm at paragraph 7.16 in your statement, because as I understand it, prior to the April admissions guidance, PHE had been developing its own internal operation guidance for healthcare protection teams to effectively manage outbreaks. And can I tell you where I'm going, just to help everyone else following? What PHE were working on does not accord with what appeared in the April admissions guidance. Do you agree with that as a very broad proposition?
So I think actually lots of it does. There are a couple of elements that do not, and I think it's worth pulling those out a little bit more. Yeah. My understanding, and again, from the teams who were doing this and from the health protection teams who were developing this to help them in their job, that this was being done to help the teams do it in response to the NHS guidance that had been released. Right. So my understanding is this guidance had started to be developed on the 22nd of March. Okay. So it was very much a first draft, while then the department asked for the agencies to come together.
If we look at paragraph 7.6, this is what PHE were going to, in developing the guidance at that stage. They make the point that decisions on transfers need to be carefully considered, taking into account local epidemiology and capacity. Put aside the healthcare tracking, but go down to the general principles, if I may. Thank you very much. Transfers into the care home, where there is an ongoing outbreak of COVID-19 in the care home, PHE were intending to advise against any transfers of asymptomatic patients into the care home to avoid presumably them becoming infected by the care home that's already got the outbreak. Is that right?
Yes, and again, this would be predominantly people coming from hospitals or the community, so it would affect both, where people are returning from a hospital or returning from the community. That's particularly challenging, I think, in the element where you're trying to ensure that you've freed up beds in hospitals. So it's recognising that. And I think, again, it's clunky language because it talks about patients, so I'm not sure where those patients, if it's a hospital patient, for example, versus a resident.
But it was going to be PHE's position that if the care home has got an outbreak, you don't send anyone into that care home, in a nutshell.
That's generally regarded as the scenario that they would try and follow. But I think you can see that if there is a situation where that somebody needs to be admitted to the care home where there is an outbreak, you would try and segregate those individuals from other individuals who are known to be infected.
All right. If we scroll down a bit further, where the care home's got a single case of COVID-19, ideally, all transfers in should be avoided to protect new residents, but if appropriate, facilities for isolation and cohorting of asymptomatic contacts can be assured, then transfers can be considered. And if there's no COVID in the care home, previously confirmed cases of COVID who have no longer got symptoms and they've been isolated can then be transferred. Now, do you agree that on any view that is a more restrictive approach than what ended up in the 2nd of April admissions guidance?
I absolutely agree this is more restrictive. I also think there are things in this that probably wouldn't have got through all the phases of clearance in the organisation because of some of the language that's been used. But I think that from my point of view, the point of the consensus guidance that came out was that it was bringing together the views of all of the organisations involved, the Department of Health, CQC, NHS England and PHE, to agree the balance of the risks and benefits for both the discharges from hospital and to protect the care homes. So I don't think it was binary one or the other.
In due course, there are emails where NHS England certainly were concerned that this might create blocks in the system. Their phrase, not mine, I hasten to add. Do you think, however, that PHE should have held a firmer line and said, I'm afraid, if we've got cases of COVID-19 in the care home or no cases, there does need to be more restrictions on allowing admissions in?
So I think this is always a sort of balancing act between organisations and a balancing act of what the directions are from government as well, actually, as an executive agency. So we can talk on the evidence and we can talk on where we know there's evidence and then where we have unknowns at the time. At this point in time, there was a priority to free up beds in hospitals and that was one of the priorities for government. I think when I look at this and balance it with the other component, the piece that I would say in retrospect, as we've moved on and understand more about the virus, is how can people come into the care home and then be safely isolated as much as possible in the care home, is the piece that could have been strengthened in this, rather than all of the elements that are sitting here in front of you in this guidance.
Sorry to interrupt, but had PHE been more insistent about what precautions should be taken, it might have forced other government organisations or departments to consider step-down facilities or something. In other words, not taking a COVID-positive patient, because they were a patient before they're discharged from hospital, and putting them into a care home when you had a lot of very vulnerable people.
So step-down facilities were considered and were part of the plan, as I recall, both on the 17th and subsequent 19th of March guidance that was released from the NHS. I think clearly it depends every day an individual, and especially an elderly individual who remained in hospital, as hospitals were rising with the number of cases of COVID, also increased their risk of getting COVID. And so there was this worry at the time that if individuals stayed in hospital for a prolonged period of times, then they were having an increasing risk of COVID.
No, but we're talking about somebody who's had symptoms, already been COVID, already got COVID.
So the individuals with COVID who had symptoms, in the discharge guidance, they were only accepted to the care home and isolation facilities for them. That was on the guidance that came out in April. Individuals who'd had COVID in hospital, confirmed and treated, unless they had completed prolonged isolation period, they were asked to be isolated in a care home or were sent to another facility.
Thank you.
So that's really clear.
That.
No. We would not have accepted that. The challenge is the individuals who had been in a hospital, who had no symptoms, and where the risk was rising. It's those individuals who had no symptoms that I think is the the piece in the middle that there was an argument about.
Thank you.
Thank you. So may I ask you, Professor, you mentioned there a number of times about the need for be able to safely isolate patients. Did PHE know how many care homes had the capacity to safely isolate?
I don't think, I certainly wouldn't have had a number. We did know the structures of care homes, and locally, between the local authority and the health protection team, they could have had that discussion. Care homes were generally mixed. There was very few care homes that shared bedrooms, but there were many more care homes that shared bathrooms. And therefore, it was, could you isolate a single bathroom to a single patient if they needed it? Could they use a commode in their bedroom for that short period? Were all of the things that would have been considered. Or if they had to share a bathroom, how could the bathroom be cleaned after their use? So it wasn't as binary as if they didn't have a bathroom, they couldn't use a bathroom. But what are the elements that you could do that would clean and protect the bathroom from being a transmission risk to others? And all of those require the care home to think about it for a risk assessment. And this is not just for COVID. They would do this for norovirus in care homes or flu in care homes as well.
You say in your statement that, thank you, that can come down, that there was a meeting on the 24th of March between PHE officials and NHS England in which concerns about the guidance were discussed. And I think on 25th of March, you say this, recognising the pressures on acute beds, PHE agreed that we go ahead with the NHSE proposed changes. In short, discharge anyone who is fit, as IPC guidance will be able to mitigate the risks. My paraphrasing. Why did PHE agree to go with the NHSE position?
So I think what that's saying is that as I've just already highlighted, if an individual had diagnosed COVID-19 and needed to complete their isolation period, they would need to be isolated in the care home. But if individual was asymptomatic, had not been clearly clarified as somebody who had symptoms with COVID-19, then those individuals would be able to return to a care home. That was the bit of contention. And at the time, the challenge, as I understand it, was trying to find the balance of freeing up hospital beds and ensuring that we didn't keep people in hospital beds whose risk would increase every day they stayed in hospital for COVID-19. And also then ensuring that we protected the care homes in as much as possible at that moment in time. We can look back at that and say we would take a different risk judgment now, but that was the risk judgment that was taken at the time.
Can I just do with one final piece of guidance, perhaps before we take our mid-morning break? On the 8th of April, there was guidance for those who provide unpaid care by friends or family. Can I have up on screen, please, INQ 327821, underscore page 6. This is guidance from the 8th of April. And one can see there that for unpaid carers, face masks were not recommended. They are not considered an effective means of preventing the spread of infection. Is that right, as at the 8th of April, Professor?
So at the 8th of April, as unpaid carers, so this is people in the community, we were not recommending for the general population face masks in general. That came sometime later. Clearly at this point in time, we were recommending widespread use for face masks in hospitals and care settings and other closed settings at that point, but we were not recommending them in the community, and that follows the sort of general community guidance and written in respect of that for unpaid carers in the community who were often family or friends of individuals.
You say face masks play an important role in clinical settings such as hospitals where staff are trained in their use of PPE, but there is little evidence of benefit from their general use outside of these settings. Can you help me? Upon what was it based, the phrase, there is little evidence of their benefit?
So clearly it wasn't any COVID-19 studies because there wasn't any time to do them at that point, but it was based on years of evidence for respiratory infection about the use of face masks to prevent the spread of respiratory infections when community outbreaks were happening, particularly flu, preventing infection infections in households, in transmission when the individual who's infected or other members of the household wore a face mask. And there were multiple other attempts in both populations or in settings to see whether face masks reduced the risk of spread. In the vast majority of them, actually in all of them at that time, there was no evidence that these were an effective measure of reducing it. I think what was different and what we came to recognise with COVID-19, going back to some of the evidence in Module 3, was even a small benefit of reducing spread was something that we should utilise, which is why we moved to widespread face mask use in the pandemic, and why I think in a future respiratory pandemic we would use them much earlier, be it cloth if we had a shortage of paper ones, but that idea that there is an element of a barrier and that we would take any element of a barrier to reduce spread.
Thank you very much. Would that be a convenient moment?
Certainly. I shall return at past.
Thank you, my lady.
Ms. Carey.
Thank you, my lady. Professor, we were in April 2020, and can I ask you briefly about the Easter 6 study, which was conducted over the 10th and to the 13th of April. It's at your paragraph 3.31. But in a nutshell, this was a study of 6 care homes in London, the result of which showed that 43% of the residents tested were asymptomatic. I know you give the full figures in your statement, but time precludes me from going there today. And you also say that the study showed multiple lineages in each of the 6 care homes, suggesting there'd been an outbreak. That in each outbreak there'd been multiple introductions of the virus. Just help me with what you meant by that.
Yeah, so I'll take the background numbers as read in the statement, but the lineages just to explain. So viruses mutate as they spread from one person to the next. And by doing genetic analysis of those viruses, we're able to look at the amount of times it is mutated. And we're able to then determine whether those mutations are related to each other. So it could happen from moving from one virus person to the next, which might have 1 or 2 minor changes in the virus. Where we see changes that are more than 10 changes or more than 20 changes, then we know those are very separate moments of entry. What this was really important in doing and highlighting was that in a normal outbreak where something comes in and spreads around the care home, we would see that all of the viruses that we detected were very closely clustered together, usually with 0 to 2 or 3 changes in the virus genome. When we say that there's at least 6, it means that at least 6 are so far apart from each other, they had to have been introduced separately from separate events. We can't say there may be some that are on the borderline, which is why we won't go and say we think there's 10. We'll say where we think the minimum is. And I think it really highlighted to us was that there were multiple ways that viruses could get into care homes, which we knew before we started, but it really helped us. It helped us determine that actually across these care homes, the same virus was in different care homes, and those care homes could be linked by workers, they may be linked by a hospital. There was lots of different linkages, but it showed that we weren't seeing something go into a single care home, spread, and then close down, that they was moving from care home to care home. And it was the first time that we saw that. We were also, and again, this is the important bit from an asymptomatic infection and transmission, we could see that individuals who were asymptomatic and also had the same virus with somebody who was symptomatic. And so it started to give us some more insights, recognizing that this study was done as a point in time. So we didn't know who was negative at the start and when they became positive, but at least it made us understand that this wasn't one thing that happened to one care home. It was lots of things happening across care homes in general.
And you said that each cluster of outbreak included a member of staff, indicating a strong likelihood that staff played a critical role as a vector of transmission of the virus.
Yes, and again, you know, if something had come into a care home by one route and then spread around the care home, for many other infectious diseases, we would see that very few staff were infected, for example. Whereas here we could see that there was lots of different incursions, and that each different cluster that we could see clustered around a staff member rather than clustering around a group of patients, group of residents who lived on a particular floor, for example. So it may be residents on different floors, or it may have been in different ways. And it gave us some insight into how the infection was spreading.
Do you know, because on the 15th of April, the action plan was published, did Easter 6 findings feature or factor into the guidance that came out on the 15th of April in the action plan?
So, I went through my records on dates. I don't think we had the full data on the Easter 6 by the time that happened. But what we were seeing and the insights that people were talking about that weekend, because when we literally had people go out to the care homes and come back and report, that was definitely feeding in, because that was being reported on a daily basis to our calls that we had together, where people were reporting on what was happening. So it was, in effect, the health protection teams who were dealing with the incidents and outbreaks that were reporting to the national teams, reporting to the individuals who were looking after adult social care nationally and in government, reporting to the CMO. All of that was coming together. But my recollection is that we first sent the report up on Easter 6 less than a week after we did the study, which it might seem normal, but that's quite exceptional in trying to get something written up and sent up. But we were getting insights on a daily basis.
The 15th of April action plan announced that there would be PCR testing for all patients discharged from hospital into care homes. It started with those admissions from hospitals, and then it was rolled out from admissions into care homes from the community. Can you help? Were there any statistics or data to support the decision to focus on testing patients from hospital into care homes first before the rollout to the community?
So I think, and again, I think this is, the information and the intelligence. And I use the intelligence word as a way of collecting information that was being highlighted to us from care homes. So care homes were reporting that they could see an individual come from a hospital and then some clusters. Of course, that was something they could recognise as an event. They couldn't recognise where the infection may be coming in by a visitor or by another resident or by a staff member, because those things were happening every day. But we took that seriously, and in taking that seriously, we decided, well, that was one single intervention that we could do. I will recall that there was quite a lot of discussion, because there was worry that by doing a PCR test on a resident, patient turning into a resident as when they get into a care home, it might give a false sense of assurance or reassurance. So my recollection on the April the 15th guidance, or shortly thereafter, we also said to isolate those individuals coming from hospitals. So we were trying to mitigate what we could as the knowledge and evidence was emerging, and we're trying to reduce the risk of infection outbreaks in care homes through lots of different measures.
There was some how to work safely guidance published on the 17th of April. Initially, how to work safely in care homes. It was then 10 days later for how to work safely in domiciliary care. Can you help why the two pieces of guidance were not published at the same time? Why was domiciliary care later?
So I can't in absolute know why it was done differently. I can only speculate at this point that it is likely that the adult social care was prioritised, and that the work on that was therefore done first, and then work with domiciliary care providers and others took place afterwards. But I don't know exactly why those were published on different dates.
Right. Two things. May I ask you to slow down slightly?
Of course.
A message from the stenographer, please. And secondly, this. You just mentioned there that the care homes were prioritised. Can I just ask you, Professor, there's certainly a sense by some of those working in adult social care that care homes were prioritised first, then domiciliary care was looked at, and then unpaid care was thought of in third place, my phrase, not anyone else's. But do you think there was such a hierarchy in terms of getting out guidance for the different parts of the social care sector?
So I think there was a recognition, first of all, that this was affecting all parts of society, and there was also recognition to prioritise areas where the most risk was potentially occurring and where the most infections were being reported, so that we managed the components of that. I recall, I think there's a note of a meeting with the Secretary of State where he asked the priority to be care homes. And as an executive agency and as agencies working, we would have therefore followed his recommendation.
All right. Just sticking with the how to work safely guidance, could I have up on screen, please, INQ 000571064? And could we go to the page 4? This talks about the guidance that was issued, how to work safely for home care, that had been published a few days before. And essentially there's an email here, Professor, to help you, from the Home Care Association. It's copying in PHE and DHSC. But there were a number of concerns raised by the Home Care Association about that how to work safely guidance. And we can see them there set out. Suppliers were offering masks that don't conform to that published guidance. The specification wasn't right. They didn't have sufficient stocks. There was said to be a disparity in the guidance between two tables that recipients of the guidance were asked to look at. And thirdly, a massive discrepancy between the requirements of PPE and the available supply. And so this was brought to the attention of PHE. And if I could just follow the email thread back to page 3, we can see, sorry, page 2, it's my fault. There we are. Page 2, we see at the bottom email in this chain, Ros Rawton asks colleagues of yours at PHE, anything we can do to expedite a response to the UK Home Care Association's concern? It will really help providers. And then if we follow up on the email chain, Eamon O'More is going to reply saying, thanks, Ros. The PHE and his team are having further meeting about this. But now, on the specific question of compliance for the masks with standards, I'm advised that it's for HSE to advise on PPE standards, and there is a single point of contact, a SPOC, and it gives the email to suggest, is that useful to go to them with your query? And then if we go up the page once more, Dr. Jane Townsend, on behalf of UK Home Care Association, says to DHSC, I'm very unhappy at being fobbed off by PHE in that way, being signposted to a faceless generic email address. We consider this to be rude and dismissive. And she points out the number of people that are in the Home Care Association. Thank you for agreeing to find a real senior person for us to engage with. We very much appreciate your support. Tensions and feelings may be running high, but nonetheless, there is a concern brought to PHE about the practicalities in a number of respects of that guidance, and perhaps an answer that wasn't as practical as it could have been. Can you help with why PHE weren't able to tailor the guidance or respond to Home Care Association's concerns perhaps as quickly and as properly as they ought to have done?
I mean, I'm looking at this not having been involved in any of it at the time, and the vast majority of the people involved in this are no longer in the organisation, so it's quite difficult to actually even go back and ask them their recollections. I would highlight two things. The first is that the Health and Safety Executive were the people who decided the requirements for each level of PPE, and we had a lot of time discussing it with their chief scientist and with their advisors at that time. But of course, we in PHE could not give out their personal email addresses. That would have not been the role for us as an organisation. And we in ourselves were also using their Spock email to contact them. Again, because it's a 24/7 response that they were doing, like many of us. So rather than emailing an individual who may be out or in meetings, trying to have Spock emails was considered good practice, so a single point of contact. So I sort of look at that and go, well, we were all trying to have somebody who could answer an email promptly rather than give it to a named individual. So that's one aspect. On the other aspect, I mean, I recognise and I really do remember the moment in time where the challenge of getting the right masks out to people, the varying differentiations of the masks, were they type 2, were they type 2, or were they type 1, what could be used safely, was a very big discussion point. And actually, part of this came down to what was in health and safety legislation and required in health and safety legislation versus what we thought was good enough at the time. And actually, again, I think rather than looking at this and trying to understand what happened, I think the thing for us is to have a clear listing of, if you don't have this mask, then use this as a protection element. And I think I would reflect that, the more widespread use, even at this time when there was a lack of proper, high-quality, fluid-resistant surgical masks, of advising people to use a cloth mask as a measure, may have been helpful. But that was felt to be a line that we hadn't crossed before. And so people were very anxious about going into a new direction in this space. This is this sort of element where I think discussing with the people, the population, and outside an outbreak setting becomes very helpful.
Can I jump forward in time now, please? Just quickly deal with a couple of different issues. In your statement, you have a section dealing with rapid evidence reviews that Public Health England were asked to conduct. And in a number of different points in the pandemic, starting on the 13th of May, PHE were asked to identify and examine evidence of transmission of COVID-19 within care homes and in domiciliary care. But you made the point that in relation to domiciliary care, there were no studies identified. And if I can wrap it up, that persisted through a number of different reviews into 2021. Why was there such an absence of evidence relating to transmission in domiciliary care?
So I'll try and explain this, and I'm sure domiciliary care providers would be much better at doing this than I could ever do it. But if you like, domiciliary care providers are often commissioned by local authorities, by the NHS, to provide care in someone's home. But some of them are also private providers, so they may be commissioned by a family relative like you or I might do for our parents, for example, to provide care in their home. And so from my understanding is that there was a very large number of domiciliary care providers. The majority, but not all, were CQC registered, depending on whether they met the CQC registration criteria. They were delivering care in different people's homes, and it may vary from week to week, so it wasn't clear the individual. There were, and there are no central records of who domiciliary care is being provided to in this country, and that remains the case. And so trying to understand who the care is being provided to, the level of risk to those individuals, trying to understand the way through to the domiciliary care providers and understanding, they describe the 650,000 individuals here, how we get that information in the right place was something that was really being built during the pandemic. It's wrapped up to some extent now within the adult social care and the social care forums that remain in place. But I still think it is a difficult, challenging area to understand what the guidance should be and how the guidance for caring with somebody in their own home, often for short periods of time, and where that line is between an individual and carer and provider lie. So I think it is the challenge of that. And it's also, I think, the challenge of that the majority of this is outside central government, if you like. So it's very much sits within local government and the local system in what is paid for by the local system versus what is paid for by the individual themselves.
You've enunciated there a number of the challenges with conducting studies in the domiciliary care sector, but do you consider that UXA, as it now is able to remedy that research gap, or is there any work going on to try and understand better transmission routes in domiciliary care?
So it's really, I mean, I maintain it's extremely difficult because it's essentially looking at transmission studies in individuals' own homes, which are, again, when we talk about care homes and the complexities of who visits people in a care home and who is involved, that complexity is even greater in someone's own home, where a domiciliary care provider may visit any time from a couple of times a week to multiple times in a day, but for short periods. And they may have other family members living in that house with them who may have multiple ways of moving in and out of that house and other visitors. So I think pinpointing routes of transmission in that setting will always remain complex. What we tried to do during the pandemic and what we will try and do in any future pandemic is work with academic researchers to try and understand transmissions in households. And I think in looking at those studies, we will work with the academic researchers about whether they can have more complex households under study that may involve types of domiciliary care. But those studies require the consent from the individuals, and it also requires quite a lot of testing. So when we did household transmission studies, it required us to test the index case and all the household residents every day over the course of a few weeks. And that can be quite challenging, especially if someone needs care themselves.
Can I turn to Vivaldi, please? We heard from Professor Shawcross last week that you approached her on the 8th of May about the need for the Vivaldi study. Are you able to tell us briefly, please, Professor, why you asked Professor Shawcross to set up Vivaldi?
So I'll put it in three ways, if that's okay. So the first is the staff in PHE who are doing epidemiological studies, including the Easter 6 study, were working flat out. We were hiring new people all of the time, but we had a limited number of people to deliver the studies that we were already doing. We had people who were trying to do response and guidance, and as well as laboratory testing. So people were really working at their maximum limit. So that's the first thing. Second of all, while we had done the Easter 6 study and while we have done some small studies in care homes before, I knew from Laura Shawcross's research and some engagement I'd had with her that she had developed a very strong relationship with the Four Seasons care home, one of the reasons why it became known as the Vivaldi study, as part of her research that she's doing on antimicrobial resistance, which is why we had interacted. And thirdly, I also felt a bit like the ONS study. There's quite some value of an external organisation in doing these studies, as they have the ability to be independent and be seen as independent, while I believe and continue to believe that our research is independent and we are able to do research and publish research independent from government. I think at this point in the pandemic, with the care home work, I really thought it would be beneficial to have somebody who is outside government conducting that work.
Did you get any sense from others of your colleagues in Public Health England they didn't want the Vivaldi study to take place? Was there any reticence or reluctance about finding out just how bad infection rates were in care homes?
So I literally do not recall that. I mean, I think there was some upset that I had gone externally. Just because people consider themselves as able to do all of these. But as the incident director at the time, I was balancing the resources of all our teams and what they were needing to do.
So can I just interrupt you there? Does that explain why Vivaldi could not be done in Public Health England, as it were?
So, I mean, we were really limited by our resource at the time. And I think the number of studies that we're trying to do were challenging. I myself was one of the people who raised the idea, but I had just started the Siren study and I had got quite a lot of people engaged on doing it. And I was worried that we were going to spread ourselves too thin and therefore using external partners, which we do all of the time and which many academic researchers were involved in. A lot of the research work in the pandemic was a way of building that resource and expertise. And Laura is has training in public health and work in adult social care, so it was a perfect person to take this on.
Well, we've heard from her about the results. I'm not going to ask you about them, Professor, but can I just ask you about perhaps the data sharing that led to the Vivaldi results? I think there is a concern that perhaps there was difficulty in getting Public Health England's data into the NHS Foundry, which was then used by Vivaldi. Were you aware of those difficulties?
So I was aware that there was generally difficulties in getting the data across to Foundry, but that wasn't just for Vivaldi, it was in general. And it was trying to ensure that the COPI notice that came out originally, so that was
Control of patient information?
Control of patient information, was directed to NHS Digital and was not including Public Health England and its data. So we had to get specific advice about whether we could put all of this data into this domain. What I would say from that is we need better ways of sharing information across government departments and the health and care sector all of the time, and not need to construct them in emergencies.
All right. Was the COPI notice varied then to enable Public Health England?
We were given legal advice that we could follow it.
All right, fine. Just one other question, please, about Vivaldi. Mr. Hancock, in his statement, made the observation that in the summer of 2020, Public Health England was the source for his view that staff movement was the main source of transmission. Are you able to help with whether there was any PHE research, paper, information provided to Mr. Hancock which may have led to him believing that staff transmission was the main source of transmission as opposed to a source of transmission?
So clearly I listened to Mr. Hancock's evidence last week, and we asked the teams to find if there was a document. We cannot find a document that relates to that. Clearly this will have been discussed, particularly in adult social care ministerial meetings. I was not in those adult social care ministerial meetings, so I don't know the word and framing that might have been used. I think the Vivaldi report, of which I was a co-author, so I was quite clear on it, highlighted the variety of different ways that infection could get into care homes, and was able to show that staff movement across care homes, lack of sick pay and other factors was a route. But as I recall, it detailed that it couldn't determine the relationship with hospitals, partly because of missing data.
Do you know whether Public Health England tried to present the Vivaldi data as its own?
No.
Just finally on guidance, I suspect we've talked about it enough. You may be familiar, Professor, with a concern that guidance came out either too late or last minute on a Friday, was not sufficiently clear or was contradictory. From a Module 6 perspective, as I know we've discussed this before, were you aware of complaints and concerns like that? And if so, is there anything practically that can be done to try and prevent that in the event of a future pandemic?
Look, I recognise this, and it was really a difficult moment when basically if people were releasing guidance on a Friday. You'll recall that I discussed this a lot in Module 3. And we really tried to not release guidance on a Friday. What that meant was sometimes guidance was ready on a Friday and held over till Monday, which then talks about the delay of releasing it. But there was also always nuances. To move to the future, and I think the future is really important in this setting, within our adult social care team and our infection prevention and control team in UKHSA, they are currently working with the adult social care sector, with a very wide group of stakeholders, to set up infection prevention and control guidance that will be the basis for anything for the future. And they're taking the time to do that, to do it right in consultation right now, in order to have the basis and principles for any future epidemic or pandemic, and which is what we would utilise in the future. And I think that's the right way to do it, to have as much of this bedded in, to work through the problems, because trying to work through it in a week in an emergency with 10,000 care homes and lots of different organisations is an extremely challenging time. And I can look back and reflect and say we could do it better, but I still think it wouldn't have been optimal.
A different topic, please, and hospital discharges. And I think you said this morning that you weren't aware of the NHS England's letters that were about to come out on the 17th and 19th of March. In your statement, you say you weren't formally aware. Does it mean that PHE were informally aware?
Well, I mean, we've gone back and tried to check. I mean, I can't say somebody didn't receive a phone call or our comms team weren't made aware, but it was not emailed to us that we can find in our records. The 17th was definitely a surprise to me as the incident director. I think the 19th we were expecting something further to come out, given the 17th letter.
All right. What I'd like to look at, though, perhaps in slightly slower time because it's important, is the data linkage report at INQ 234332. and if I can have up on screen, please, the executive summary. This was a data linkage report published on the 1st of July 2021. And thank you, if we just scroll down, we can see there that from 43,398 care home residents who tested positive between the 30th of January and the 12th of October 2020, it ended up that 97 of those outbreaks, or 1.6%, were identified as potentially seeded from hospital-associated COVID-19. I just want to hear from you, please, what one can deduce from this and why the data linkage report was asked to be set up and what it shows us.
So the SAGE, so Science Advisory Group for Emergencies, and the Social Care Working Group, sub-group of that, and also, as I remember, the National Audit Office report brought together and said that we need to look at the data that we have and try and understand how best we can understand hospital-associated infections into care homes. So this was a piece of work done by one of our epidemiological teams where, as always, they set out very clearly the case definitions so they can track and follow things over time. And what they do in doing that is they define what they believe is a hospital-acquired infection versus a hospital-associated infection. Associated meaning the individual may have spent some days in a hospital, but some days in a care home, so you can't determine the cause and effect, whereas acquired means that they were in hospital for a period of time and then stayed in hospital and got this infection.
Right.
So we have different ways of looking at those things. In this in particular, they also looked at whether the incident case that was detected, so the positive case, was detected as the first case in a care home, or was detected within 48 hours of the first case being detected. So in that very immediate period where you might have missed it, or they may have been potentially pre-symptomatic or asymptomatic and transmitted to someone else and not tested first. So it was trying to basically come up with robust definitions using the data that we had, which was the Pillar 1 and Pillar 2 testing data at the time. Mainly Pillar 1, of course, until late May, early June. Yeah. But Pillar 1 and Pillar 2 testing. Link those to a care home residence postcode. And again, not perfect, but the best that we could do. And then utilising NHS digital hospital records, determine which of those individuals had been in hospital in the preceding 14 days. So quite a lot of data, linkage, all of the hospital records were looked at, all of the testing records were looked at, and using definitions that were predefined, coming down and rolling through to meet this particular criteria.
So are we essentially saying that if the person caught COVID in the hospital and then was discharged to a care home, you could track it through to work out whether that hospital-acquired infection ended up seeding infections in the care home? Or is that too simplistic a summary?
If they had had a positive test. So recognising we could only do this if they had a positive test. And I will highlight that, and we did highlight in the report and for any publication that followed it, that we recognise that particularly in March and April, there were less testing done than was done later when we started to do whole care home testing.
Yes. Now that's an important caveat because clearly it's covering a longer period of time, but certainly in the early months, there wasn't the capacity of testing that we had later on. Can I just ask you that, though? Do you think this executive summary, and I appreciate the full paper does add that caveat, but do you think there should have been that caveat highlighted in the exec summary? Or limitation might be a better way of putting it.
I mean, usually the executive summary highlights the main facts that you found. There is usually a discussion section that highlights all the potential caveats, such as testing amount, the size of the care homes or the other components.
Now, some people may think that the 97 positive cases, or 1.6%, call it which you will, seems a very low number of potentially outbreaks coming from hospital-acquired infection. Were PHE surprised by that number?
Yes.
Did you think it was going to be higher?
Yes.
what did you do when the findings came out?
Well, we looked at all of the
Response
other
surprise?
data that we could find. Was there any other data that we could find that we could see and look at? I mean, I think then we looked at the fact that maybe the individuals weren't tested when they came from hospital. Maybe they remained asymptomatic, as asymptomatic infection and transmission was definitely more on our awareness by the time this report was being done. We looked and checked that we had the best matching that was available. Were we missing things? And I think, again, with all of that, we then continued the study for the rest of the pandemic so that we could look at it over time. I think the thing I would say, and I think it's really important, I think there is what we call an epi curve in this report. There's definitely more epi curves in the final report. What that is clear is that the vast majority of the infections in the care homes and the outbreaks in care homes occurred from mid-March to mid-April. And I would say that was the period of the real challenge in testing. But one of the reasons why we went on to continue to do this over time to try and understand it better. And even subsequently, when we were doing whole care home testing and whole care home repeat testing and outbreaks, despite there being other measures, care home outbreaks being seeded by hospitals ran to 3 to 4% in the winter of 2020, when lots of other care home outbreaks were caused by other reasons. So I think in time we were like, clearly this was an underestimate, but we did not know, and we cannot know in retrospect, what the real estimate was.
Because of the lack of testing, particularly in that key month. May I ask you for your comment on this? Mr. Hancock gave evidence that he considered this was a spurious level of advocacy. What did the PHE say to that? Accuracy.
Well, I mean, this is clearly delineated in the report. We report numbers in reports. We often then go and look at what's called a confidence interval, but I don't think a confidence interval would have helped us here. And actually, given all of the variation and the explanations that we've talked about, would not have really brought anything to light. It would have told us that the number of outbreaks in a care home range from 0.5% to 3%. I don't think that would have materially changed the outcome here, which is the reasons for this at the time were multi-varied and multi-focused, and if anything, the underestimate was based on the lack of testing rather than what the true estimate was.
May I ask you, so that we can have your views on it, did PHE want to show low figures of infections being seeded from hospitals, given its role in formulating the guidance and perhaps some of the, with hindsight, flaws in that guidance?
So my belief then, and my continued belief now, is that my scientists have a high degree of ethics and propriety. They design studies and they publish the methodology for those studies. And then the reports that they publish are related to those. They do not hide data. And if they did so, they would be up on ethical misconduct. I believe that then, and I believe that now, and that is the expected behaviour of all our staff.
Thank you very much. Can I turn to visiting, please, Professor? And just a few questions on this. I know there was various guidance that was put out in due course in relation to visiting, but can I ask you, please, about your paragraph 8.22. And in November 2020, the SAGE Social Care Working Group published a consensus statement on family or friend visitor policy into care home settings. Thank you very much. It's on screen if it helps you, Professor. And the key findings from that there was a lack of evidence on the risk of introduction and transmission of infection from visitors. All this partly may be due to timing of policy changes in the first wave. Can you help from Public Health England's perspective? Was there any research done on how much infection was brought in by visitors, or was it not possible to do so because of the ban?
So I think it was really challenging, wasn't it? It was the so first of all, in the early points, there was always something about visitors, as there wasn't always in preceding guidance, and reducing visitors in situations of incidents and outbreaks or infections. From my point of view, I think that in order to understand, like, the lack of evidence means that there was no evidence available for us to see. And when people looked at it, not just in studies that Public Health England had done, but other studies around the world, there was nothing being published that said the visitors were bringing the majority of the infection in, or even the minority of the infection in. But there was clearly a risk to it, and remained a risk in both directions of visitors potentially bringing infection in, and visitors also then potentially acquiring infection and visiting a care home and transmitting it to other members. So I think that, that's where we came to. That was what we talked about. I think this was really at a point in November 2020 where the visiting restrictions had already been in place for quite a long time. The increasing social distress of residents and of their families was increasing as time went on. I know myself, I didn't see my parents for 20 months, and that was a long time. And so at this point, I think we were trying to see how we could possibly get the right level of visiting in to keep the risks low, but to ensure that people had the right social environment for their longer term care, because this is no longer an acute and emergency. We could all see that this was going to last quite some more time.
Two things, please, on that. Is there any work being done now by UKHSA or anyone else to perhaps try and work out the extent to which, if at all, visitors brought in or are capable of bringing in an infection? I
mean, this comes back to what I talked about really for domiciliary care. You would have to have testing of visitors all the time. I would say that in the following winter, when Omicron was present and when Omicron was circulating in high prevalence in the community, we did get visitors to test going into care homes, and we did detect in visitors going into care homes people with high levels of virus through those lateral flow tests, and therefore they were excluded from visiting. I think that sort of approach was useful as a protective measure once we had a test that we could use in real time. I would argue that a PCR test was not good enough for that, because the time to take it, get it to the laboratory, get the results, and then do the visit would have taken too long. But it would be nice to be able to see, when infection is circulating at high levels in community, how we could enable visiting for the residents and for the individuals who are being visited, and reduce the risk of infection.
The inquiry has seen some evidence that makes reference to an ongoing piece of work being conducted by UKHSA to quantify the benefits and risks of visitors. Are you able to give us, Professor, any update on that piece of work?
Yes, so this was using a tool that was developed actually many years ago, as I understand, by researchers in adult social care looking at quality of life tools in adult social care. It's called the ASCOT tool. And it's a piece that is there for adult social care managers, care home managers, and other individuals who provide care, to look at the risks and benefits of the care that they provide, and how that can improve the quality of life of residents in care homes or in other settings. What UKHSA commissioned post-pandemic is working with some individuals who are experts and developed this tool, is to develop a set of teaching slides and tools that could be used to get people to really understand the individual. And those training slides are now used by our guidance teams so that they consider the individual whilst developing guidance. And those training slides have been disseminated to local authorities and to care providers. And we can share those with the inquiry, but what it really does is it puts an individual at the centre of the guidance, and then asks what changes in the quality of life you're doing by each of the aspects, and gets you to do an assessment of that. And it also asks you to think about what's the deprivation of liberty, what are the changes that you're making, and how that might affect them and their family. And I think it's really good because it brings person-centred care to the centre of developing a guidance. And so we are now utilising that to train people about when they write guidance, and using it as a training tool for others. And we're waiting for the formal academic report from it about how that tool is being evaluated with the sector.
A different topic, please. I'd like to ask you about data and surveillance by PHE and now UKHSA. And I think you say in your statement at paragraph 11.8 onwards that there were clearly some weaknesses in this area at the start of the pandemic. Either there was no data, or the data that there was not linked and not collected in a standardised way. And indeed, last week, Mr. Hancock made reference to one of his WhatsApp messages from July 2020, where, to use his phrase, not mine, that he had no tolerance for crap data, by which he was referring to PHE data. Help us, please, with what were the real practical issues with either, well, obviously with having no data, that's obvious, but with the non-linkage and the non-collection in a standardised way?
Yeah, so and I would say that data improved quite dramatically through the open sharing of data and the COPI notice during the pandemic. But much of that, as I recall saying in Module 3 as well, has returned to baseline. The data that we receive from laboratories on confirmed cases often only has a name of the individual, the date of birth as they're required. We ideally receive the NHS number and their postcode, but many of the postcode of the residence of the individual is not complete. That's preceding the pandemic, and while it's better now because systems have been put in place, it's still not perfect.
Can I just pause you, Professor?
Yeah.
Because we've heard that from a number of different witnesses, and it sounds so straightforward just to put on someone's postcode, and they're like, what is the difficulty here?
Well, for example, say the care home or the GP in the community is sending the sample with a form, and they don't include some details, then the hospital laboratory or the laboratory receiving it don't have those details. We try and utilise being able to link it up to what's called the NHS spine, but sometimes the details are wrong on the form, and therefore you just have missing data. We would all like if it was better, and it is much better than it was, but it's still far from perfect. But it doesn't say if the individual is residing in a care home when we receive the sample. And so, as I mentioned earlier, we have to infer that sometimes from using the postcode.
Yeah.
But that's not perfect, because for those of you who study geography and geographers, usually 30 houses are within the same postcode. Sometimes a bigger care home would have its own.
Yeah.
But that's the challenge that we have in trying to make those assumptions.
And do you know if anything is being done to try and remedy what are on any view potentially quite basic pieces of information being included?
Yeah, so, I mean, there's stuff being done, but not enough. And there are some components that I think we could improve on. It might, require more than gentle encouragement. But I think, so for example, at the moment, GP records don't include, by definition, whether somebody is residing in a care home when they're looking after them. That's pretty straightforward. We could improve that we knew if someone was being admitted to hospital that they were in a care home, because at the moment it can be recorded that they're coming in from a care home, but it can equally be recorded they're coming in from their own residence, which of course they are. So those sort of things would make at least linkage of data easier and better. I do think, though, we need to think through what we would like to see from care homes. And is that...
That's what I was going to ask.
Okay.
Two things then, please. When you delicately said that they might need more than gentle encouragement, what do you actually mean by that, Professor?
Well,
do you mean legislation, regulation?
Yes.
What are we talking?
If you want something to be done, even though it mightn't be done perfectly, legislation is where you start, because that requires people to deliver something. Everything else is on best endeavours.
We've heard there's no national or no relevant national data system. What do you say on behalf of UKHSA that it should cover?
Well, so, for example, we hold an NHS number uniquely, each of us, and we hold that from cradle to grave. And I recognise people come into the country at different ages, but they get given an NHS number. Somehow linking who is in a care home and the CQC registration number with that NHS number would be a huge step forward in allowing us to understand infections better. And that's, I suppose, where I come from, is at least recording that in GP records and making it available would not be as big as infrastructure change than asking for a new separate care record system to be introduced. Because everyone in a care home should have a GP. Yeah. And therefore, including it on the GP record and being able to extract that easily from the GP record would be a big step forward.
And would that, it sounds obvious, but play an important role in UKHSA being able to track infectious diseases, track other data trends that they need to monitor? Is it really that straightforward?
So if we,
It helps you
if we're,
surveillance.
if we were then able to access all of the, if we were able to access that data and we had permissions to utilise it, we can link it with all of the infection data that we receive and are able to generate reports.
Is access now difficult in the absence of a COPI notice?
So, but again, that can be delivered by regulation.
Mr. Hancock said to us that he thought there should be a national centralised database on all communicable diseases run by UKHSA. Does UKHSA have a view on that, Professor?
So UKHSA, as did prior organisations, collects data under the health protection regulations, which are regulations that allow us to require individuals with potential syndromes of disease, which are the suspected COVID calling us, or GPs who see someone with chickenpox or measles. We also have the ability to collect laboratory data from a variety of infections that are listed. We do not have all of the infections that can occur. Each of those infections that are put on and each of the laboratory have to go through a system of review, public consultation, and ultimately secondary legislation in order to deliver it. Personally, it would be of great help to us if we could collect all of the both positive and negative data, because that would allow us to know who was tested and what we did during COVID-19, but what we would only have at the moment for COVID and flu and a small number of respiratory viruses. Tests data that was performed, because that would allow us immediately to track who's being tested and who's being positive and be able to link that. That does require not just regulation and legislation potentially, but also technological funding, both to the laboratories that are doing it at the moment and to UKHSA. Capacity. The scale and size of that may be too large for the current financial climate, but that's what is required, regulation and technology to interface this.
Moving aside from care homes for a moment, you say in your statement that whilst rapid progress was made with outbreak surveillance for COVID-19, this was intrinsically much more difficult for domiciliary care, I suspect for the reasons that you already outlined. But is there anything that can be done or is being done in relation to trying improving domiciliary care data?
So again, I think this is even a step more complicated than care homes, because whilst I said GPs will know who's in a care home and each GP will be looking at it, domiciliary care can be transient, so it can be in 1 week and it mightn't be on the next. So that will be much more difficult for it to record. We are not recording anything centrally in UKHSA, partly because our focus is on infections. So I think that question on domiciliary care would probably be best answered by the department and on what they may wish to collect in that setting.
Couple of final topics, please. You mentioned at the beginning of your evidence that UKHSA has now established a dedicated adult social care team, albeit that the size may expand or contract depending on any outbreak. Do you know whether that team includes considering the views of stakeholders, including those who are recipients of adult social care?
Yes, so the adult social care team works with the social care and adult social care stakeholder fora, which has patient representative groups on it and resident representative groups on it. My understanding is that where possible, they are looking at the views of residents in care homes. And I think it's really important that it's not just the residents in care homes, but their families who can often express their views, especially if they've got dementia or complex care needs, very well in advocating for the care that they require.
A couple of observations, please, that we've heard about in evidence that I'd like UKHSA's comments on. Mr. Hancock told us that he found it difficult to get PHE to take on board planning assumptions based on asymptomatic transmission, and he was critical of the advice not changing until April. What do UKHSA say about that?
So I wasn't in meetings with Mr. Hancock in March and April. I started meeting him in May, as I recall. I think that, as always, we were being driven by the evidence that we knew from prior infections and from before. This evidence was also getting discussed with expert advisory groups, so with multiple experts from across the country, through NERVTAG, New and Respiratory Viral Threat Assessment Group, through SAGE, Science Advisory Group for Emergencies. And I think the consensus view at that time that asymptomatic transmission was a small part or a very minimal part to play really changed over that time period. And I think by mid-April, we were recognising it more in the UK. But I would note that WHO were reluctant to mention it, and I think their first mention of it was probably 3 months later. So I think we were trying to follow the science, trying to learn the evidence as we went along, and trying to express that. I think I might reflect that ministers were learning a lot of new things at that time. And we know that not everything can be taken in through rapid meetings, often 30 minutes covering a lot of components. We were trying to express that evidence in the best way that we knew. And it may have been that some people were more certain about the evidence that they knew than they might otherwise have been. One of the things that I learned in communicating was to communicate my uncertainty. We increasingly use the probability yardstick as a way of identifying how certain we are about things in a way that we can describe on a visual scale, as well as making a sentence and stating it. And I think that's really important in emergencies, that you try and write it down, you try and state how certain you are of and how confident you are in it, and you try and communicate uncertainty. And perhaps if that had been clearer, then ministers may have changed their decisions, but may not have either.
Do you think that communication of uncertainty is something that perhaps should have featured to some extent in some of the guidance that we looked at earlier this morning?
And I agree, and I think that the challenge always in guidance is to simplify it and boil it down to the simplest things. But I do also think that communicating uncertainty in the face of an emerging pandemic is really important, and also trying to ensure that people are aware of what we're trying to do to improve our uncertainty.
Finally, in your statement, you set out a number of different recommendations. I wasn't going to take you through all of them, Professor, but is there one particular one that you would urge Her Ladyship to consider? It doesn't even have to be one that's included in your statement.
I will always go to. Can I go to two? So is that okay?
Yeah.
Just
you've
two?
got 5 minutes.
I'll do it quickly. So the first one is, I think developing guidance, because it's such a big part of this pre-pandemic, and having principles for guidance laid out in advance of an emergency, so that we are able to bring in stakeholders' views, the lived view, into that guidance, and people understand why we're saying things. For me, is really important. And the second, I think, is everything that we can do to improve data allows us to assess things better in those early days and ensure that we're able to evaluate the interventions in the best way possible. Where I think the first is we can do within the resources that we have in UK HSA. The second requires a whole of government and a whole of system approach, and does require additional finance for technology and data and digital to put together. But data is critical in being able to make decisions, especially in emergencies.
Thank you very much. My lady, they're all the questions that I asked.
Thank you, Ms. Carey. Ms. Morris. Ms. Morris is just there.
Thank you, my lady. Good afternoon, Professor Hopkins. I ask questions on behalf of the COVID Bereaved Families for Justice UK. I'm going to ask you questions on 3 topics. I'm grateful to Ms. Carey for covering in some detail one of my topics I was going to address with you. That was around domiciliary care. I'm going to focus my questions, first of all, back on the March 2020 hospital discharge policy. You've used the word in your evidence today that you were surprised on the 17th of March 2020 by the DHSC policy. Should, in your view, Public Health England have been cited on that policy at the ground level rather than being surprised?
So it was in NHS England, not DHSC, just to... so clearly, as organisations who send out information, we don't see all of the information that goes out on a routine basis today or any day that goes out to organisations. However, what we learnt in the pandemic and what we learned really in events like this was that we needed a single clearing system, which is what we developed. It was a single clearing system for all guidance going out that was clear on who saw what when and how it went. But that was not in place in March.
So the learning was, yes, we need to be cited. Does it follow then that you should have ideally been cited on this when it happened?
So we should have been. I don't think it would have necessarily changed what we could have done at that time, but I think we should have been cited.
Thank you. In her statement for Module 3, Amanda Pritchard, the then Chief Operating Officer, the NHS, said that on the 17th of March, discussions took place at the NHS National Incident Response Board meeting about the hospital discharge guidance. I think you were also at that meeting with Miss Pritchard. And there was discussions in that meeting around consideration to be given about testing practices at the discharge point to support safe care home discharges. Did PHE take that issue further, that consideration of testing before discharge?
So I don't recall that meeting. I don't know if I was at that meeting. I definitely don't have any recollection more than 5 years later on anything that you're mentioning now.
Okay. So do I take it from that answer that you don't recall PHE being tasked to consider anything regarding testing from hospital discharge into care homes?
No.
Were you involved in any conversations at PHE about whether discharging policy could be deferred pending further capacity building around testing?
No.
Ms Pritchard went on to say in her statement that by the 1st of April, NHS England understood that a large number of hospitals may already have moved to be testing symptomatic and some asymptomatic patients before discharging them into a care home. Was PHE made aware of that?
So not that which hospitals were, but I think I included in our statement, and we have records of numerous people saying, if you can test and you have capacity, then please do. This is not a decision of no testing required, but it's a balance of prioritisation of your testing needs. So I don't know what individual hospitals were deciding at that point.
Okay. So her evidence is that they thought some that may have been, but you say that PHE weren't aware that.
So we wouldn't have known which hospitals?
Okay. All right. My question is then, if there was some testing going on, does that indicate a recognition by clinicians within the hospital at that stage that there was an on-the-ground appreciation that it was inappropriate to discharge patients to care homes without that testing where there was capacity to do so?
So I think what we were trying to do is understand where we could test more. So, if, for example, in hospitals at that time, individuals may have been tested because they were developing symptoms in hospital. They may have been developed because they were a contact of a case in hospital. And they may have been tested because that if there was capacity, it would be good to know before they were discharged. But this was a balance of ensuring that the individual was at the right place for their residents, for their ongoing care, and ensuring that the testing capacity was prioritised to the individuals who needed it for their own care.
So whilst recognising that testing doesn't remove all risks associated with, for example, asymptomatic transition, do you agree that the requirement to test before discharging into care homes should have been introduced before April 2020, 15th of April?
So first of all, when we introduced it on April 15th, 2020, it was really important that it was introduced not just as a test and discharge, it was a test, discharge and continue in isolation. Partly because we really did not know at that point in time what a negative test meant. So, for example, a positive test we were very clear on, but we did not know how long a person would be negative before they became positive. And so there was a lot of anxieties about the false reassurance of a negative test at that time, and it continued for some time. So I think from my point of view, this was a balance on what capacity there is in testing, where do we prioritise that capacity, which we were prioritising to test in care homes. In hospitals where they had capacity to test, we had a list of criteria that we had sent to them in early March about how they would prioritise testing in hospital, which included being a contact of a case, etc. So that would have been part of the considerations, I think, rather than just purely discharge testing into care homes. It would have been one of the many considerations hospitals would have done in prioritising their testing.
Moving then to the April admissions guidance, you've been asked some questions about that 2nd of April, what I think you've termed it the consensus guidance. And Ms Carey, King's Counsel, has touched on some of the underlying emails that were exchanged around the 24th of March on the topic. One of those emails referenced from the Deputy SRO for PHE, Professor Johnson, who noted that, quote, mustn't be pushed into agreeing the consensus guidance. He also said that he'd only found out on the 24th of March that this guidance was being written at all. So there seemed to be some surprise expressed that this additional guidance was being prepared. The internal PHE emails record that in a meeting, there's a view expressed by Mr. Wynne, the NHSE Director for Ageing, and his team, that, quote, the overall balance should be about reducing the risk of care homes not taking back existing residents or new transfers. And it was noted in the email that their words were that, quote, it should be made clear to care homes that they should only refuse patients in the most extreme cases. An email chain the following day shows that you reviewed the NHSE changes and that ultimately they were agreed by the PHE. So do you agree that the NHSE insistence that social care should only refuse to admit transfers in, quote, extreme cases was incorrect, having regard to ASC governance arrangements and their providers' duties to safeguard residents within those care homes and their staff?
So I think that at the time, there were two very diametrically opposed components that we were trying to bring together in that consensus guidance. I think it's really important that care home providers are able to do an adequate risk assessment for their individuals who they're admitting, and that equally the NHS needs to understand the views of the wider sector whilst they're developing guidance as well. I think it's really important that we remember the moment where the hospitals were worried that they were not going to have sufficient beds to care for individuals. And we had seen that take place in other countries in Europe and in North America. So it was a real live risk. However, I think my view is that coming out of this pandemic and where we are now, we should really look at what we can do to balance the needs on both sides. And that needs to bring together the care sector more eloquently into the centre of this conversation rather than aside.
I appreciate that forward-looking sort of recommendation, but on the 24th of March, between then and the 2nd of April, you were very clear to say you're sort of trying to find a balance, but was the reality that PHE was pushed into adopting this wording with fewer safeguards for the adult social care sector?
So I think this is, as I've said, a consensus. So there's not being pushed one way or another. PHE, I think at the time, highlighted when somebody with COVID or known to have COVID was coming back, what that needed to be done. It highlighted what needed to be done for individuals who were asymptomatic, who developed symptoms. And it was trying to draw that balance between ensuring that there was spaces in hospitals and safety in care homes and a recognition in care homes in what they could do. So I think this is a balance on both sides, and as always, being brought together by the Department of Health to look across the different systems and bring the whole system together.
My third and final topic is returning to the issue of data, please, and in particular the PHE linkage report, because you say in your statement that the evidence suggests that hospital discharge was not the dominant cause of outbreaks and that outbreak levels were broadly consistent with infection rates in the community. There's no caveats in your statement, and you mentioned in answer to Ms Carey's questions about whether there are any caveats in the PHE linkage report from July 2021 itself, and that can, of course, be checked. You accepted, in response to Ms Carey's questions, that the PHE data linkage report was based on the Pillar 1, in part on the Pillar 1 data that PHE had been using in 2020, if I've understood that correctly.
The data in the report's Pillar 1 and Pillar 2.
Yes, but the Pillar 1 data is limited up until May 2020.
That's the only data that was available till the start of April. But from April, it was Pillar 1 and Pillar 2.
And the important caveat to that is that the Pillar 1 data had limited testing capacity available to it.
Well, Pillar 2 had none. before that started in April. So Pillar 1 was the only capacity that was available to the country until April.
Understood. So, and you've accepted as well this morning that it's likely that that 1.6% is likely to be an underestimate, and the limitations, the caveats are around the testing capacity at that point, that data point. If we put it that way.
Correct.
Thank you. So there are limitations, there are caveats that can be applied to it. Mr. Donaldson, who is an official at the heart of the COVID-19 response and an official responsible for creating the Vivaldi study, suggested that therefore extreme caution should be utilised when trying to understand the PHE linkage report. Would you agree with that?
So I think the initial report was developed, and the subsequent fuller reports that are in peer-reviewed publications were also developed. And actually, they look at the same data and as it was developed over time, over a prolonged period of time. So even in the winter of 2020-21 and the subsequent period of time, the amount of infections that were able to be diagnosed coming into care homes was extremely low, despite whole care home testing being available. So, of course, we should always be cautious on data. We're cautious on all aspects of data, and particularly in the data from March, April, where there were limitations in testing. However, the data, as I've said previously, lays out the definitions that's utilised, lays out how the data was analysed, and applied that consistently over a prolonged period of time to try and give the best assessment they could from the routine data. Always should have cautions in the data. You always need to understand how the data is developed and delivered, but it's clearly described in the reports and in the final peer-reviewed publication.
All right, thank you. Mr. Donaldson goes on in his witness statement to tell the chair that he, quote, repeatedly witnessed how relevant members of PHE and SAGE, who had overseen and failed to warn against or properly mitigate the tragic initial errors, consistently used inadequate methods and extremely faulty data, which played down the seriousness of the problem in care homes. Would you agree?
So I'd like to see Mr. Donaldson's evidence. I don't recognise that.
And in his concluding remarks, and it may be helpful because it's a lengthier paragraph for this to be put on the screen, please. It's INQ 000598578 at page 35. You're likely to be able to read quicker than I can speak.
It's not on the screen yet, so.
It's at paragraph 111 of Mr. Donaldson's statement. Thank you very much. I'll just read it for the record. He says, in summary, we had to create Vivaldi because PHE and DHSC ASC policy teams had failed to do so. We had to use outsiders because they wouldn't and perhaps couldn't do it themselves. Parts of PHE and DHSC ASC effectively tried to stop Vivaldi happening, then tried to stop it reporting, then tried to avoid acting on the results, then tried to stop the creation and use of our data dashboard. Having tried to stop our initial report, PHE first tried to ignore it, then tried to steal it and present it as their own, then tried to reinterpret it as justifying its own previous policy failings. DHSC refused to share data, even when ordered to by ministers, and regularly proposed not telling ministers important information. I believe that this all suggests a pattern of dysfunction that helps to explain why things were so bad with care home policy making at the start of the pandemic and gives a broader clue as to the systemic problems COVID revealed. What's your response to this statement?
So clearly, when we talk about PHE and DHSC, it talks about large umbrella organisations. The organisations were increasing in size very, very rapidly. I was at the centre of Vivaldi creation, as I've said in my previous statements, for Module 7. And also I've seen Laura's statement for Module 6, which I had not seen until it was released. So from my point of view, clearly as a member of PHE staff and as the incident director, I was involved in its construction. So some of it just doesn't recognise to me. I discussed its development and its production with the adult social care policy team, as I would, because I wouldn't do these things by myself. And clearly, I already highlighted why we went outside, resourcing numbers of technical experts and the ability of studies like this to have independence. I did everything I could to facilitate it personally, and I know that lots of other people did too, in order to get it through ethics committee, write protocols, ensure that we get the data across. So, what I would say is the organisations were very big and they increased very, very rapidly in this time. And I have no doubt there was friction. And I have no doubt that there were individuals who were worried about components of it. Is that how it felt to me as the incident director? No. People were by and large trying their best. Sometimes you had to get things done a bit faster. Sometimes you had to mobilise resource from here to there. But that was part of acting in an emergency and a response. In terms of the results, I thought the results were really important. They were presented at the data group, which John Hatwell, one of the officials in the department leading Pillar 4, brought together, where I was presenting the siren results at the same time. So we were presenting the results in real time, often off the top of our heads in doing it. We were relying on lots of people to share those data across organisations. And we were putting them into Sage and to other components as fast as possible. Clearly, sometimes it was not fast enough, right? I completely sit back and go, how could we have done things faster? But people were really working very hard. I never saw people steal data, though I'm sure that people were presenting slides that other people had utilised for another presentation over here, or there were 2 meetings going on and different people did it. So for me, this just doesn't recognise and feel how I worked throughout the pandemic, and particularly in those early months of Vivaldi. We continue to support Vivaldi as NHS Test and Trace, and we continue to support Vivaldi now as UKHSA. I think it's an important study. It was the first of its kind in the UK and globally. And from me, everyone was there to support it. And I just don't recognise this.
Thank you. Those are my questions. Thank you, my lady.
Thank you, Ms Morris. Ms Beattie. Ms Beattie's over there.
Thank you, Professor Hopkins. I ask questions on behalf of disabled people's organisations. You tell us in your statement that the PHE existed to protect and improve the nation's health and wellbeing and reduce health inequalities. Is that generally right?
Correct.
Yes. Now, on the 15th of May 2020, the ONS released data on deaths involving COVID-19 in the care sector. And that covered deaths among care home residents and deaths of recipients of domiciliary care. And if we could have a particular page brought up on screen, please. It's INQ 000252648, page 16. And while that's coming up, that showed that for the reporting period, there were 3,161 deaths of recipients of domiciliary care in England. And it's the second paragraph in that page, if it could be highlighted, please. So there were 3,161 deaths of recipients of domiciliary care in England. This was 1,990 deaths higher than the preceding 3-year average for the same period. And just to make that easier to understand, I think that's a 2.7 times increase in the rate. But the ONS also said that the proportion of the increased deaths which involved COVID was lower for domiciliary care than for care home residents. So my question is, did the fact that there was a much higher rate of death, 2.7 times in domiciliary care, but a lower proportion of deaths which involved COVID, require further investigation to identify whether that significant increase in domiciliary care deaths was due not only or not to COVID infection, but to other aspects and indirect impacts of the pandemic response?
So I'll start this by the framing. I think the CMO, Chris Whitty, has used this in the past. So when we were considering the impact of the pandemic and the impact of COVID, not only did we consider the direct harms of COVID-19, but the indirect harms of the fact of the things that we were doing in order to reduce transmission of COVID-19, and balancing those and trying to look through them at those different lenses at different times. So I don't know why this was, but one can speculate that it is if individuals were having less domiciliary care, if they were having less family and friends visiting them, then they may have got sick and died and not been recognised. It also may be that these were not quoted on the death certificate, because that's what ONS would have utilised as being suspected COVID. So recognising that at the time and all the way through the pandemic, on the death certificate, when you use the words COVID-19, you can use them where the clinician who verifies the death considers that COVID-19 is either causing or at least partially responsible to the death of the individual. So the individuals who were certifying the deaths may not have recognised that COVID-19 was an influence, or it may have been another cause. Clearly, there's lots of different reasons for this.
Right. So, Professor Hopkins, you've said there that one can speculate. Aside from speculating now, what further review or investigation did the PHE carry out at the time, once it was known that there was this very significant increased death rate, but possibly due to other factors?
So again, we looked at lots of different death statistics, and we produced excess mortality death statistics throughout the pandemic from PHE. That's now done by the Department of Health with the Office for Health Improvement of Disparities, looking at excess deaths for lots of different reasons. And we know that excess deaths in the community were also related to other causes, such as ischemic heart disease, such as other pneumonias. So I don't know on the exact cause of each of these domiciliary residents, which we would have utilised the ONS data to try and understand this better. But clearly the key component is that the Public Health England would have utilised the data that was available in order to try and understand all of the causes of excess deaths, which were wide-ranging.
Did it result in any changed guidance on domiciliary care and how that was being managed as part of the pandemic response?
I can't tell you whether this exact report resulted in a piece of guidance change at this distance, I'm afraid.
And I'd also like to ask about visiting restrictions and the March residential care guidance, which you were taken to before. It doesn't need to be brought up, but that said that care home providers should review their visiting policy and that the review should also consider the well-being of residents and the positive impact of seeing friends and family. Now, people with learning disabilities, people with dementia and those with communication needs may be especially reliant on their family and friends, including for daily communication about health and welfare needs, to communicate fundamental things like experiencing pain and discomfort, and indeed to receive care itself. And I think you commented on that earlier in your evidence about families often being able to express those views of people with dementia or complex care needs. Is it right that beyond that broad reference to the wellbeing of residents and the positive impact of seeing friends and family, that March guidance was completely unspecific about those needs that would need to be taken into account by residential and care home providers in deciding on visiting? So
again, I think this was building on evidence and guidance and how care homes manage care home admissions all the time. So I think that it wouldn't have been something that in this emergency guidance that we would have gone into how they would do that and what they would do that. There would be an expectation on care home managers that they would be able to do a risk assessment and decide which residents might need a family or visitor to visit them, which residents would be able to do that remotely via phone or others. And that would really be to the local authority directors of adult social care, local authority directors of public health, as well as the health protection teams to support care homes if they had questions on that.
So in the context of all the messaging about stopping visits, was it enough to rely on homes to do, I think what you're saying, that you think that they would have always done, rather than expressly setting out that where visits were not possible following risk assessment, there needed to be alternative means provided so that those communication needs could continue to be respected and people would not be isolated?
So I think that is a valid point that I think came through in future visiting guidance, as I recall. At the point, this was trying to reduce infection in care homes, so it was not the focus of this guidance at that time.
And I think you say in your statement that you consulted the department's group of trusted stakeholders on guidance and including specifically on getting feedback and suggestions on guidance content. Was that done for this visiting guidance, or what was said in this guidance about visiting?
So as I recall, and as is in the statement, the March 17th had some stakeholder group involvement. I think the stakeholder group involvement got better over time. So I don't think it was probably optimal at that point.
Thank you, Maddie.
Thank you very much, Ms Beattie. That completes the questions we have for you, Professor Hopkins. I'm not allowed to make guarantees, but I'm fairly confident that we won't have to burden you again. So, and I appreciate it's not just a burden on you, but it's a burden on the colleagues who help provide the statement and then to support you in coming here today. So thank you for all the help you've given so far.
Thank you very much.
And I hope it's the end. I'm sure you do. 5-2.